All right.
Okay, who
So
wants
what
to
did I
do the
miss so
intro?
far?
Nothing. Uh, I don't know, Holly, do you want to welcome people or
Sure. Hi, everyone, and welcome tonight. And thank you all for coming from not just here in Connecticut, but from all over. So we thank you for joining us. And if this is your first time, welcome and please continue coming. We are all in this together. And the more we stay in solidarity, the more we can get done. So we appreciate you being here. Phil has been with us for a while now. He is with Physicians for National Health Plan program. I get the P's
Program.
program. Sorry, Phil. He is a
I have to tell
retired.
you,
Go ahead.
they were formed in 1987. I've been a member since the formation, and I still sometimes say Physicians for a National Health Plan and Physicians for a National Health Care Program. So, yeah,
Oh, okay. So I'm not the only one. Okay,
either
Phil.
one's
Thank
fine.
you. Thank you. Pete, you're funny. Okay. Pete said he was also formed in 1987 for those of you who didn't see it in the chat. Um, but anyway, so Phil is a retired emergency room doctor, and he has brought so much to Medicare for All Connecticut and PNHP. As you heard him say, he's been since the formation of PNHP. So thank you, Phil, for being here and for always doing some great presentations. And we look forward to hearing from you tonight. So take it away, Phil.
Okay. Um, Let me start by just um, or asking around the table, so to speak, or what you're interested in as far as healthcare goes, or what do you know? What are you clear about? What do you know about Medicare Advantage? What do you know about the history of healthcare in this country, et cetera? Any?
well, if no one else wants to start, I will. I am, in general, interested in the idea of universal health care. Like many people who have been advocating for this for a long time, I lived outside of the United States for a while, had kids born in a system that I never saw any bills. And I wouldn't say the medical care was fancy, but it was, more than competent. And now that I'm a retiree, my obsession kind of is that my spouse was a state employee. So we are covered by the state employees insurance, which is, Medicare plus the state does the copay. Uh, but about 3 or 4 years ago, they forced all of us from traditional Medicare into Advantage plans. And although on the consumer side, we haven't really seen a difference because the state still picks up the slack wherever the primary insurance doesn't. Um, I really was concerned about what the impact of moving a huge pool of employees or retirees from traditional Medicare to a Medicare Advantage plan. And I think we're on our third different insurance company sponsoring the Advantage. So I haven't personally had the problem, but I suspect some people have had to switch their physicians around to match the plan. So that's my spiel.
I
So
can go. I can
go
go
ahead.
next. I'm a veteran single payer person. I've been working on this in California for the last 23 years. We had a bill, AB 2200, that was stopped by Newsom about a month or so ago. We think, and it was excellently best written single payer bill ever. But we think he's going to run for president in 2024. 8, and he doesn't want single payer as an albatross. In looking to follow the money, he gets a lot of money from health insurance and the doctors and dentists who are against single payer. Just want to get a little plug. Progressive Central was a gathering of progressives at the DNC, met in the Chicago Teachers Hall. That whole section on Medicare for All, a panel from Mila Jayapal was there both days. Medicare for All was heavily discussed for the 2 days. So it was excellent, and I'm sure you can get it on tape. And I want to put a plug for one payer states. We are the group that is state-based, single payer throughout the country. We don't have a Connecticut representative as such. We had Stephen Romdor, who's in Florida, and he is on our board, but it would be great for at least one of you to attend our meetings and help us in this search. We also are working hard on SABUCA. I don't know if you know about that, State-Based Universal Health Care Act. That's the latest we're trying to get passed because that will enable the waiver, obtaining waivers. And it could also mean that several states could band together and have one, regional plan, such as New England, Washington, Oregon, and California. So that is talked about in this bill. We're trying to get co-sponsors in both the Senate and the House. Thanks for having me, and I can't wait to hear what you guys are doing.
Thank you, Lynn. Oh, sorry, David. Did you want to go? You're on mute.
Sorry, the name is David Englert. I live in Connecticut in West Hartford. I'm interested in a single payer healthcare system. I admire Bernie Sanders. I still have a Bernie Sanders bumper sticker on my car from when he ran for election for president. I've been going to the one payer states Zoom calls for a while now, and I'm very impressed by them. I've sent letters to my senators asking them to support the SABUCA legislation. All I've gotten back is a form letter from one of our senators. I think it's time for me to follow up and see if I can get a little more of a response from them. I do think we have to go far beyond a single payer system for financing healthcare. We have to do something about the pharmaceutical industry, and we have to do something about the hospitals, something about private equity moving into healthcare and filling their pockets from the government treasury. And we obviously have to do something about Medicare disadvantage, which is just a means of the insurance companies filling their pockets from the treasury. I just sat for 2 hours this morning at a hearing in Hartford at the Legislative Office Building, listening to testimony about rate hikes for 3 insurance companies, up to 13% this year. They complain that the costs are the main issue. Pharmaceuticals and hospital bills, I believe them. That's for sure. So we're not going to solve this by just doing something about the insurance companies. And what we should do with insurance companies is just get them the hell out of the business entirely. But that's not going to solve the problem. There are some much deeper problems that we really have to address.
So I agree with what everybody has said, but my specific issue, I have Medicare. I did have Medicare Advantage for a while because I was swindled. You cannot, a lot of doctors do not take Medicare Advantage because they don't take like United Healthcare. They don't take a Cigna plan. They won't take well, most people do take the Blue Cross Medicare Advantage plans, but they won't take those they will take regular Medicare, but they won't take the Advantage plans. So even if they're in network and you call, they're like, nope, we don't take that. Nope, sorry. So it's very hard to get, especially specifically specialists appointments when you have an Advantage plan. You can't get into specialists with an Advantage plan a lot of times. Specifically mental health. A lot of mental health providers, believe it or not, would rather take Medicaid than Medicare, specifically more so than Medicare Advantage, because it's a lot worse to go through their billing. And you get the denials and the delays and all that other stuff that we've heard about. And personally, my mom had to wait and was told she had a brain tumor removed the size of a grapefruit. And her Medicare Advantage plan told her no, she couldn't get an MRI every 3 months like her neurosurgeon told her, but that she'd have to wait for a year. Okay? Even when the doctor said no, she needs it every 3 months for the first year, and then she needs it every 6 months. They still said no. So these are the things that mostly concern me, because as a my mother watches this, so I have to be very careful. So as someone who would rather find her own way instead of listening to her child, she still has a Medicare Advantage plan. So I am very concerned at the way that they're continuing to swindle our older folks and those of us with disabilities. And that really scares me, because we are the most vulnerable populations, and it's gross. So that's my personal issue and issues.
Good. Anybody else? Well, that's great. So let me tell you a bit about where I'm coming from. So I during my senior year of college, between the senior year of college and starting medical school, I did a summer what was called a preceptorship, the urban preceptorship in Chicago, with Quentin Young. Quentin Young was the chief of medicine at Cook County Hospital, an ardent Marxist and an ardent supporter of not-for-profit healthcare, healthcare entirely financed by taxes and so forth, Medicare, basically, to make it as simple as possible. And the summer preceptorship was basically designed to indoctrinate young minds into understanding why that was the best way. And so I was brainwashed very early on, and nothing I've seen since then has told me that he was wrong, or that his worldview was wrong. He was absolutely right. I then went to France and studied medicine, lived there for 8 years. And of course, France has single payer nationalized healthcare financing. And it's important to make a distinction between socialized medicine, or let's just call it socialized medicine, which for me is not a dirty word, versus socialized healthcare financing. And in the first case, such as Sweden, it's a socialized system. All the hospitals, all the clinics, all of the staff are employees of the national healthcare service, just like in a public school. Everybody there, well, I guess now they outsource some of the things, but basically everybody works, they're paid for, employed for by that government. France has a system where it's more like Medicare, meaning everybody pays through their taxes for the national healthcare system, but the system itself, the healthcare delivery itself, is through a combination of public hospitals, private hospitals, and mostly private practices, medical practices. It's a mix. You can go your entire life and only see physicians and get healthcare in public hospitals. But for the most part, people will have a primary care physician who is in private practice. But all of the money that pays for that goes through government hands, and the government sets the fee that the doctor can charge you when you go see the doctor. And the fee for an office visit is reimbursed 85% by the National Healthcare Plan, and the other 15% is on the patient, which is, I'm convinced, how Medicare came to the conclusion that they would pay for 85 cents on the dollar and the patient would pay 15 cents on the dollar. And just like with supplemental insurance, most employers in France will offer a supplemental insurance plan that you retain as long as you're with that employer. And you can also buy it privately, just like with the supplemental plans here. But the bulk of the expenses are through the national healthcare system, the national healthcare finance system. So in my experience there, people worrying about how they were going to pay for healthcare and all that was absolutely not part of my experience there. And the World Health Organization has an annual ranking of the quality of care, quality of the healthcare system of all the countries. And year in, year out, France is either number one or number two. And when France is number two, it's because Italy is number one, and vice versa. They kind of trade places. We're generally, depending upon which ranking you're talking about, we're always far down the list. Typically, we're like 47, somewhere between Burundi and Cuba, or Slovenia. Yeah, I think it's Burundi and Cuba the last time I looked. So you know, this mantra that we have the best healthcare system in the world is absolutely not true. We certainly have some of the most advanced healthcare in the world, but our system as a whole is far below the 32 industrialized countries who have some form of national health care. So that's my experience. And when I finished my residency and came to Connecticut to start the emergency medicine program at Yale, which was in 1988, PNHP had just been formed. It was formed in 1987. And so I've been a member as long as almost as long as PNHP has existed. So where are we? Where were we then, and where are we now? And it's hard not to be discouraged. We've lost ground over the years. We've had two publicly financed systems. Well, I'll take that back, but two of the publicly financed systems are Medicare and Medicaid. Medicaid, of course, has the pejorative aspect of it being medicine for poor people. And so it's second-class medicine for second-class citizens in the eyes of many people. Many physicians do not accept Medicaid patients And in some ways, I think it does more harm than good, as opposed to expanding Medicare to encompass people of limited finances. And then the other one, of course, is Medicare. And there are other systems. There's the VA system, which provides medical care for a large number of people. And then a number of other entities, the military, for example, and so forth. In the intervening years, we've lost ground, and we lost ground in two major steps. One step was the creation of Medicare Part D. One of the big gaps in Medicare coverage was that it does not cover pharmaceuticals. And so under George Bush, in an attempt to convince older voters that they should vote Republican, they created Medicare Part D, which was extremely complicated. Do you know what the donut hole is in Medicare Part D? That's since been eliminated, but when it was first conceived, it paid most of the cost of medications on an annual basis up to a certain level, and then it kind of quit, and everything was out of pocket until you got up to the fourth floor, and then it kicked in again. And so there was this hole in the middle that became known as the donut hole. Crazy system. It did not control costs, and in fact, it was explicitly written into the law that Medicare was not allowed to negotiate drug prices with the pharmaceutical industry. So they could charge whatever they wanted. And so inflation of pharmaceuticals began at that time and has run rampant ever since. It's called by some people the No Drug Company Left Behind Act. And unfortunately, that has turned the pharmaceutical industry into this very powerful behemoth. Of all the different lobbying categories in Washington, year in, year out, number one or number two is the pharmaceutical industry in terms of how many lobbyists they have, how much they spend per congressperson. So that's one of the big blows on the road towards a national health program. And of course, the other was the invention of Medicare Advantage. And like we said frequently at Yale, when we had trouble all the time hiring physicians and getting them credentialed, human resources is neither human nor a resource. And by the same token, it can be said that Medicare Advantage is neither Medicare nor an advantage, except for the healthcare industry. So I don't know if I'm telling you, I'm going to kind of assume that I'm telling you things that you already know, but basically Medicare Advantage is a capitated HMO, a capitated healthcare organization that takes in money from the government for each person that has signed up with them. That each person is assigned a medical risk coefficient, with a coefficient of 1 being the baseline. and then a formula that raises the coefficient to 1.2, 1.6, 1.8, depending upon your medical history, your chronic diagnoses, your age, and so forth. And so let's say, for argument's sake, for a 65-year-old woman who's just begun, who's basically healthy, who has a medical coefficient, a medical risk coefficient of 1.0, and they sign up with, let's say, Humana. Humana will receive a lump sum paid in monthly installments, but a lump sum per year to provide the medical care that that person needs. And it's on the order of, I think now it's up to $12,000, but let's just say, to round it out, it's $10,000 per year. So whatever that person needs for the year has to be paid for out of that $10,000. And if over a year they only receive $5,000 in charges for their health care, Humana keeps the other $5,000. So they have every incentive to spend as little as possible on you, to make it difficult to provide your care, because the more difficult it is and the less care you receive, the more money they get to keep at the end of the year. They have other ways of increasing their bottom line, and one of them is what's known as upcoding. Do you know what upcoding is? So if you're on Medicare, no doubt you have gotten 5, 10, 50 phone calls and maybe some letters and maybe some emails encouraging you to allow a nurse practitioner or a PA, but usually it's a nurse practitioner, to come to your home and have a 40-minute consultation where they can go through your medical record, look at the medications that you're on and so forth. And then as they present it to you, coordinate with your primary care physician the care that you are getting and making sure that it's all being done correctly, which frankly, as the husband of a primary care physician, I find obnoxious and insulting. That somebody who never saw you before and will never see you again can come spend 40 minutes with you and then have the audacity to call the physician who has known you for 5, 10, 15, 20 years and tell them what they ought to be doing. Which isn't to say that everything's always perfect and they may pick up something. But the reason they do that is they add to the list, they look for new items that they can add to the list of things that goes into the calculation of your medical risk. And so when they come to your house, you might be a 1.2, and when they leave and do their report, all of a sudden you're a 1.8. And so the amount of money that Humana is now getting after that visit can be 50% more or 80% more. They also ask you for permission to go through all of your medical records. So if you've had hospitalizations, they ask you to sign a consent form so they can go through all of the records of your hospitalizations and use that to raise your risk. And what this upcoding ends up causing is overbilling. And overbilling is a huge problem. It wasn't Anthem. Oh, I'm blanking on which insurance company it was. This was last year. And it's one of the insurance companies that's based in Connecticut. They had to pay back to Medicare $170 million for overbilling for 1 year. And it's estimated that that the total overbilling that happens, that's estimated, and this is in the PNHP report on Medicare disadvantage, is more than enough to pay for all the prescriptions for everybody for a year. Just think about that for a minute. They're robbing the U.S. Treasury, and to a great extent getting away with it. They get caught once in a while, but by and large, they're making out like bandits. So, how do they do it? How do they get people to sign up? Well, there's a number of ways. One way is when you sign up, many people, you can sign up directly, but many people go to a broker. Are any of you on Medicare or Medicare Advantage? And if you are, did you sign up through a broker or did you do it on your own, or how did you do it? Broker. Okay. So if you signed up for Medicare, the broker's fee reimbursed by Medicare was about, depending upon when you signed up, was about $600, $700, $800. If, on the other hand, you signed up for a Medicare Advantage plan, the broker got $1,400 or $1,500. So that broker is not necessarily acting in your best interest. They are incentivized to not even talk about Medicare and just talk about different Medicare Advantage plans. And unless you're informed, you're going to be directed right into a Medicare Advantage plan. And so that's one way that Medicare Advantage, that's one of the advantages, quote unquote, of Medicare Advantage. It's an advantage for the broker and an advantage for the company. Another way that they lure people in is with freebies. They advertise their freebies. You get a free silver sneakers membership in a, it's not a gym of your choice. There might be 2 or 3 different gyms in your area, but there will be at least one, unless you live in a really far out rural area, that they'll pay for your gym membership. And so for LA Fitness, which has a basic monthly membership fee of about $23, they'll pay for that. Well, $23 in terms of healthcare expenses is absolutely peanuts. It's nothing, but they will lure you. They'll say, oh, you get free silver sneakers. Yay. Free food. You may qualify to get, Meals on Wheels, free Meals on Wheels. And my 98-year-old mother in St. Louis gets Meals on Wheels, and more than half of it gets thrown out because it's pretty crappy. But that's another way. Free rides to the doctor. You may qualify for. So they lure you in by telling you all these free things that you'll get if you go with Medicare Advantage, and that gets some people in. They advertise intensively, absolutely intensively. If you ever watch afternoon rerun television with the Madlock and those shows, every commercial, it seems, is a Medicare Advantage commercial, especially this time of the year as we're approaching open enrollment season. They just advertise intensively. And of course, Medicare does not have a budget to pay for that kind of advertising. And so you never hear about Medicare when you're watching those shows. So that's a third way. A fourth way, and I think some of you might have personal experience with this, and that is if you, during your active work life, got your insurance through a company that also had, or a union that had a long-term contract to continue to provide your medical care, you may have been forced into a Medicare Advantage program. Last year, a group of New York City employees came up to Hartford, and we marched with them and picketed Anthem as well as United Healthcare. And the reason they were there was they had been on Medicare and happy with Medicare. And Mayor Adams had a creepy deal whereby the New York City pension fund converted all of them into Medicare Advantage. So many of them could no longer see their doctor because their doctor didn't take, I think it was a Humana plan, but didn't take their Medicare Advantage plan. If you have diabetes and heart issues and kidney issues and have, say, 4 different physicians that you see regularly, you will be the most lucky person in the world if you can find all 4 of those physicians in a Humana Medicare Advantage plan or a United Healthcare Medicare Advantage plan or whatever, because they have a panel, they have panels. And by some studies, when you go through the panel that they list on their website, as many as 20% of the physicians on that list are not actually participants. Maybe they were, and they're not anymore, but they're still on the list. And in some cases, they got put on the list and they never were, but it makes the list look good. And it's not until you've signed and signed on the dotted line and you go looking for physicians that you find out that it's very limited. And if you're not happy with them, there are a few alternatives. And a lot of times the physicians are no longer happy working with that HMO or that Medicare Advantage company, and they quit. And so now you've got to find somebody else. Whereas with Medicare, the great majority of physicians accept Medicare. And so you have a quasi 100% choice of the hospital you want to go to, the physician you want to see, and so forth. So that's the fourth way, by forcing people into Medicare Advantage programs. So that's the landscape right now. And where we are right now is that as of this year, the number of people who are on Medicare Advantage outnumber the number of people who are on traditional Medicare. Okay, it's been steadily increasing over the last 10 years, and now it's more than half, and it's continuing to grow. So what I want to do for how much time do we have, Rana? I
We
don't
have
wanna
10 minutes because I don't see Rep. Johnson on the call.
Okay, okay, so good. 10 minutes is perfect. So the question is, so that's where we are right now. What can we do about it? And David, I was glad to hear you were also, because that's the meeting I was talking about that I was on all day. The committee, the CIS, the Insurance Commission.
CID.
Yeah, CID. And so I logged into that at 9 this morning, and I finally got to testify at about 2 or 2:30 or something like that. Um, and and uh, um, and of course, they specifically don't deal with Medicare. That's a federal program, and so the states specifically don't. But so much about Medicare and Medicare Advantage has absolute parallels in other forms of insurance, and the insurance that the state insurance authorities deal with, that what can be said about one can usually be said. Okay.
So,
It stopped, but it's being recorded. So where are we now and what can we do? So it's discouraging. We've actually steadily been losing ground. And so are there bright lights? Are there things that we can do? And I'll just point to a couple of things. One is that one thing I absolutely have to mention, that I'd be guilty of malpractice if I didn't, and that is pre-authorization and delayed payment of medical claims. This is also a huge source of revenue uh, by reducing expenditures for the health insurance companies. Um, and I'm sure at least some of you, if not most of you, have had some experience with having your physician or your healthcare provider order something, order a medication, order a test, and the insurance company says, no, you don't need that. And they take 6 weeks to say, oh, no, you don't need that. They delay their decision, and they delay the appeal. And in many cases now, it's not a human being who actually made that decision. It's a computer following an algorithm that made that decision. And so I almost forgot to talk about that. That's a very important point. So what we are doing at PNHP this year is, and this actually came from a viewing of Fix It, which Holly and Sherry and I and Zach were at Southern last year. And it occurred to me that we should really have a concerted effort during open enrollment to educate people about the two systems, about the fact that the guy, the person who's signing you up is going to get a lot more money to sign you up for Medicare Advantage than for Medicare, and so forth, and why it's a disadvantage in many ways. And so that's what we're doing. On the 30th of September, we're organizing a press conference at the Capitol, at the LOB. And we're going to have Senator Blumenthal, who is very big on this issue, a number of state representatives, a woman whose husband probably needlessly died because of denial of care, because of pre-authorization denials. And the idea is trying to educate the legislature, and through the publicity from this press conference, educate the public at a time when many people are signing up for the first time. That's one thing we're trying to do. Another bright spot in a way is that more and more these Medicare Advantage plans are being disenrolled from participation in hospitals and hospital systems. The Mayo Clinic just 4 or 5 months ago announced that they are no longer accepting Medicare Advantage. Now, I don't know how long that's going to last, but that's a big deal. And so that makes it clear to at least some people, maybe it's not such a great thing to sign up for. And by the same token, a lot of physicians and physician practices are also refusing to accept Medicare Advantage, mainly because it takes so much time out of their practice to write these letters after something gets denied. And it takes so long to get it back. They're done. That doesn't happen with Medicare. I mean, it does, but it's rare. There's at least one health plan that has a denial rate of 60%. It's like routinely they deny things. And my wife can tell you that she'll order asthma medications for an asthmatic, and it gets denied. And so then she has to make a phone call and go on hold, and so forth. So that's, I hope, explanatory in some ways. And I hope you'll tune in for our press conference. And I have to say that we are working with CCAG on this, and PNHP, Medicare for All Connecticut, CCAG on this issue. We're all on the same page, absolutely. And so we've sort of evolved a coalition here over the last year that I think is also a positive. So
Phil, can you just tell us what time on September 30th at the Legislative Office Building, please?
we don't have a set time, but we're shooting for 11 a.m. 11 a.m. is the best time of the day to get TV crews to come out and cover it, and to get afternoon and evening coverage on the day of the event. So
Okay.
We're shooting for 11.
Thank you.
Mm-hmm.
Thanks, Phil. Okay, guys, if anyone has any questions, I'm sure Phil would be happy to answer. Unfortunately, I have to get off to go to work. So
Oh.
I will see everyone later. Take care, everybody. Bye. You don't have to leave, but I am.
Okay.
Thank you, Holly.
Bye.
Well, I had one very quick question, and then everyone can leave and we'll turn off recording.
Okay.
Is there any push in Connecticut to do what, happened in New York City, the real push against advantage plans for public employees? Because when you asked who signed me up for Advantage, it was Kevin Lembo.
Really?
Yes, because of my husband being a state
Yes.
retiree.
Yes.
And we didn't have to fill out any paperwork at all.
Yeah.
So we need the same kind of case, I think, that the New York City employees are doing.
Yeah. Did you have a choice, or was it just
Nope.
automatic? So you didn't
The
have a
paperwork
choice.
was all done for us.
Yeah. See, one of the things that I think is needed, and David, I really want you to jump in, because I thought this meeting was actually very good today. I think there needs to be legislation that requires that traditional Medicare be an option. So whoever you worked for, whoever you have your retirement benefits through, they have to offer traditional Medicare as an option. They can't herd all of their covered lives into Humana or United Healthcare or whatever. That's one thing. And
Regardless
I
of a
heard,
person's age.
sorry.
You mean regardless of a person's age?
Oh, no. Well, I mean, if you have to be Medicare
Okay,
eligible. Yeah, so I'm talking about retirement.
Yeah.
And of course, yes, our goal obviously is everybody should be covered by Medicare from cradle to grave, or at the very least, it should be an option. But yeah, we're talking about um, retirement benefits, people who are Medicare eligible,
Sure.
either by age or by diagnosis.
I see Sheldon has his hand up.
Hey,
Yeah.
Sheldon.
Hi, Phil. That was, great summary of the whole issue with Medicare Advantage. On the issue of state employees, it's just to be clear, it's not that you're prohibited from being in traditional Medicare if you're a state retiree, state employee retiree, or their spouse. It's that if you want to get the benefit of the negotiated health benefits in retirement, then you have to choose Medicare Advantage.
Right. And those
So
were good negotiated benefits.
Yeah, so that's the coercion. It's not direct. It's not required. You
Oh,
would traditional Medicare, but you give up this huge thing if you voluntarily choose that. It is highly problematic. So it's not quite the same thing as a New York deal, but I agree with Rana that some action of some sort is really appropriate to undo this effective coercion that's going on. The other thing, I just raised my hand to respond to something David said a long time ago, and that is in saying that, moving to some kind of single payer system won't deal with the basic problem, which is high costs for drugs and hospital. I actually disagree with that, because if we had a single payer system, as in Canada, or using your terminology, Phil, there's a socialist financing system, but not socialized medicine. If we had that system, then as in Canada, there'd be tremendous power for the federal government, which has a single payer system, to put pressure on the payers. It's the only payer in town. I'm sorry, not the payers, the providers, the large providers, pharma and hospitals, that here's the deal. So that is the hope anyway of a single payer system. We would be able to deal with those cost drivers, which I agree with David, are huge issues right now in our current system. They are major problems and a large source of the high expenses that we have. So, and then I did have one last thing. Sorry, I was pontificate.
Well, before you go to that
Right.
last thing,
Right.
the other thing I didn't mention was this whole phenomenon, and this came up a lot in the meeting today, of pharmacy benefit managers, or PBMs. And these insurance executives kept bemoaning how much they're paying for pharmaceuticals, et cetera. Well, 80% of all prescriptions go through one of 4 different PBMs, and they're all owned by these insurance companies. So they're complaining about the high cost of medications, but their number one profit center is the PBMs. So it's very dishonest.
Yeah.
My
So
mini rant, sorry.
my last thing was just to say that when you were saying, Phil, that this Medicare versus Medicare Advantage, you see it in other areas. For those who haven't heard my presentations about this, in Connecticut, we had that with Medicaid, and we deprivatized the system. We kicked insurance companies out of running the Medicaid program. But some of you have probably read, I think Ellen Andrews did a presentation, that Governor Lamont is saying, gee, we should go to using capitated insurance companies running Medicaid. Don't most all the other states do that? That is true. There's a handful that don't. but that doesn't make it a good idea. Just like Medicare Advantage is now 51% of all enrollees, does not make it a good thing. And it's the same basic economics. Okay, I'll shut up now.
I wanted to make
Lynn.
a comment. Yeah, I couldn't find an option for raising the hand on your thing here. Couple of things, just your updates, because I'm following this so much. A judge kicked out the New York retirees of Medicare Advantage. So a judge twice and the legislature kicked Adams' requirement to put them all on Medicare Advantage. So that was one good thing. Also on the federal level, Elizabeth Warren and Jaya Paul are working heavily with CMS about Medicare Advantage and their upcoding, their denial of care. I mean, I can't believe the story of the woman who said the mother has a huge brain tumor. Well, I'm a retired neurosurgical nurse. I mean, that's just shocking. I mean, that they should file a lawsuit. So there are some good things happening. Are you guys familiar with the SHIP program, state health insurance plans? Every state has counselors to counsel Medicare seniors on what plans to buy into, what the advantages, disadvantages, the premium and stuff. And we have a real strong one in Northern California. And I get a printout every year with my age and zip code. And because all supplemental plans pay the same amount regardless. So I always look for the cheapest premium. And I'm in the right now changing my plan to get a slightly cheaper plan that I had last year. But there have been rumors that some SHIP in some states are pushing people into Medicare Advantage. Well, that's against what they're supposed to be doing. But anyway, where I live, they're honest, and every senior should go to them because the whole Medicare maze is so confusing. And you're right about the hospitals and doctors' practices are refusing to take Medicare Advantage. So slowly but surely the word is getting out. Anyway, I'm so glad you had this presentation. It's great.
Thank you. Didn't Kaiser recently announce that they're not accepting it, or?
Oh, really? Oh, the senior advantage?
No,
Huh.
no. Yeah, Medicare Advantage. I just put in the chat. There's a couple of brokers who are actually very ethical, and this is one of them. And this is actually who I have my supplemental plan through, and it's Senior Savings Network. And the guy who runs it has a whole bunch of videos and very educational. And he's very frank that he would much rather sell you a traditional Medicare plan for which he's going to make $600 or whatever, as opposed to a Medicare Advantage plan for which he's going to, make a lot more money, because he hates Medicare Advantage. There are some people for whom it works and may have an advantage, a true advantage, but by and large, he makes sure that he explains the difference between the two, and people make an educated choice. But I recommend that you go to his Senior Savings Network website and look at a couple of his videos. He's got like 100 or more videos at this point on specific topics, but he's very good.
Well, thank you, Phil. And Representative Susan Johnson had thought about coming tonight, but we're hoping she can come next month, which will be back to being the second Tuesday. And we'll probably bring the discussion more into the fight against reintroducing MCOs into our state public health care program. We have fights on a couple of fronts. So thank you all for coming, and thank you, Phil. And we'll see you next month.
Also, one thing before everyone goes, Bernie Sanders is speaking at 8:30 at the DNC, so make sure to
Oh.
go watch that if you like.
Absolutely.